Hello and welcome to the Spinal Podcast. My name is Dr. Brian Joves, and thank you guys again for joining me on the show. I am really excited about this episode today. But before we get there, just once again want to thank you guys all for joining, for listening, for sharing the podcast. We've been exploring some different topics recently, and this week is going to be kind of along the same path where we're not exactly talking about the nuts and bolts of pain medicine, but we're actually talking about the pain medicine field at large. My guest this week is Dr. Scott Pritzlaff, who I think a lot of people know. He's an amazing physician who practices over at UC Davis, which is very close to me in location. He and I have communicated for years about patients and about serving the community, and finally had the opportunity to sit down with him and have a conversation. And honestly, I didn't really know what to expect with the conversation. Kind of, we went in and I was leaning two different directions. Dr. Pritzlaff is, I think, most known for his work with peripheral nerve stimulation, where he has even worked on the textbook spinal cord stimulation and percutaneous implantation techniques. He does a ton of lecturing in the neuromodulation world, particularly in peripheral nerve stimulation. But, I've also wanted to explore the topic of our field at large because he recently wrote an editorial that was in the Journal of Pain Research, and I will link that in the show notes. But it was titled "From Pain Medicine to Pain Surgery: How Our Specialty Lost Its Way." And I think there was a lot of people that felt some kind of way about this editorial that he made. I think some people were offended, some people were invigorated. I feel like I probably fall a lot more in the lines of the invigorated side of things because, as I think you guys can all have heard from the podcast, or if you haven't listened, please go back and listen to the prior 100 and whatever, 30 some odd podcasts that we've published. They're being able to help patients through the difficult time in their life is a great joy of mine. I think it's a huge responsibility and a great gift that we have to be able to create tools and create pathways for patients to improve and to improve their function and quality of life. And we have great tools now that continue to advance technologically. But sometimes that technology can take the forefront instead of what's at its core. And I think that's really what our conversation ended up being about. And so just to give you a little bit more background on Dr. Pritzlaff, he did his medical school at Georgetown University. He ended up becoming a flight surgeon, and then did his internship at Walter Reed. He did his anesthesia residency at Mass Gen in Boston, and then came over to California and was at Stanford for his pain medicine fellowship. He was down at Stanford, I believe, for a couple of years after his fellowship, and then made his way up to UC Davis, and has been there ever since, and is now the residency program director, and is just a really awesome guy. He really is. And so I hope you guys enjoy this. I had a great time talking to Dr. Pritzlaff and kind of just, really spitballing some ideas about the future of our specialty, and hopefully some ideas on how we can all be better as pain medicine physicians. So I hope you guys enjoy it, and please reach out to Dr. Pritzlaff and let him know that you heard him on the podcast and thought it was wonderful. So without further ado, here is my interview with Dr. Scott Pritzlaff. All right. Thank you, Dr. Pritzlaff, for joining me on the show today. Really appreciate you taking the time and spending the afternoon with me. For everybody who may not know you or wasn't paying too much attention to when I just read your bio, can you give us a little short introduction, maybe your origin story as the superhero that you are today?
Sure. Thanks, Brian. It's great to chat today. So my background actually comes from the military. After I finished medical school at Georgetown, I actually spent 5 years on active duty with the U.S. Navy, specifically a Marine Corps physician in the Marine Corps Air Wing. So that was a super transformative experience for me, how I became interested in pain and anesthesiology. I deployed to Afghanistan and Iraq and really saw a lot of things. And as you can expect, learned a lot. I did my training in anesthesia at Mass General in Boston and my pain training at Stanford. And then I've been here at UC Davis for about the past 6 years and the program director for the past four. And we have 6 fellows that we train every year, which is incredibly rewarding and yet ever moving and challenging experience as well, as you can imagine. Yeah, it's really happy to be here and bring my experience and perspective to the podcast.
We really appreciate it. I mean, I think one of the things that, when I think of your name, I think the two topics, I think I brought this up earlier, that always come to my mind are, peripheral nerve stimulation, as you've done so much education and so much work on a lot of the guideline papers that have been published, but also, continuing or medical education, right? Specifically fellow education, and how we're trying to evolve this next generation of people that do what we do as pain physicians. And so if it's okay with you, I'd like to take us down that road of maybe talking a little bit about education, and potentially getting us a little involved into a recent editorial that you presented, that I think has maybe made some people think about where we're heading and what we're actually doing as pain docs. But so you've been a program director now at UC Davis for many years. We kind of walked through the process of training many physicians to kind of learn the steps of pain medicine. I mean, when you think about where training is right now, as we're sitting in 2024, a decade removed from the era where you and I were trained in this field, where we were coming out of the decade of pain, and moving into a field that has a lot of growth, a lot of new procedures, a lot of ways that we can help patients, but still with a relatively limited amount of time to be able to train new physicians. And what are the things that kind of come to mind as we start thinking about that process?
Yeah, no, it's a good question. I mean, we have never had more option when it comes to intervention, even medication, some of the medication options that we offer for patients. I mean, you think about even a decade ago, right, when it came to folks with migraine headaches, and now there's all these CGRP
Mhm.
medications that are now available, or the emergence of buprenorphine as a modality for treating pain. But the challenge with that comes with this whole idea that there's this extremely limited period of time that was established now 3 decades ago that a pain fellowship would be 1 year long. And even when I was a fellow, you were talking very much about medical management, trying patients on numerous medications, things like tricyclic antidepressants and gabapentin, things that we know don't work very well. And then we were just doing interventional therapies that were largely focused on spinal pain, medial branch blocks, RFA, epidurals. And you are juxtaposing that landscape now where you have this whole evolving field of minimally invasive spine, which one could argue is a specialty in its own right, an exploding neuromodulation field with things like dorsal ganglion stimulation, spinal cord stimulation, peripheral nerve stimulation, and really managing those interventional therapies with how do you read an MRI? How do you talk with families, maybe of a cancer patient? And so there's a lot of this art that I think is hard to mix with all these new, I call them advanced interventions, and they're great, but in some ways they're distractions, because when I talk to candidates and I interview folks, a lot of all I hear is this whole idea of advanced procedures. How many advanced procedures am I going to do? What advanced procedures? What is the variety or mixture? But there are all these other very bedrock basic concepts that also require a lot of attention. So I think the challenge and the reality is you have this limited amount of time, and how do you dial in that secret mix with a 1 year fellowship, as long as it remains 1 year, to graduate someone that has foundational knowledge, but by no means will be a solid expert in any of these things, but really have a good foundation to build the next couple years of their practice and career to become a safe and responsible pain physician.
Yeah. No, it's super interesting. I mean, as you're saying that, I kind of think about the perspective that I've been able to take over the past decade, as mainly working in private practice, part time at the VA, but mainly in private practice, and interviewing docs coming out of fellowship or that we're trying to bring into our group. I've now had the pleasure of being able to onboard, 5 different interventionalists into our practice, interviewed, dozens more. Actually been able to do some mentoring with some of the different programs over time as people are looking for those first jobs. You bring up the people coming to you, wanting to go into fellowship and asking about the advanced interventions. And it's very interesting when I talk to people when they're coming out of fellowship, it's really one of the first things that they start talking about for their first job is, oh, well, I have the ability to do stim. Do you guys do these procedures? And it's, I think, having the maturity of time spent in the field, I think is that understanding of like, well, yes, there's obviously opportunity to be able to do these things, and they're phenomenal tools for patients in the right setting. But so much of probably not what you should be focused on when it's the first question you're asking to a fellowship director, or when you're looking at getting your first job coming out, because there's so much more to being able to help our patients than being able to put an electrical wire into a specific location.
And the reality is, and we've spoken about this, never before have we had such a more diverse field of applicants and people who are going into pain, right? We spoke about this earlier, but anesthesia applicants, we really just looked at these data this week. There were 52% less anesthesia applicants that went into pain this past cycle, the match that just happened in September. Physiatrists have really been fairly flat. There was a slight uptick this year, but there has not been some massive replacement of applicants. And then you have all these other specialties which historically had not gone into pain, things like emergency medicine, family medicine, radiology. I mean, they're the gross minority, but more than ever, we have a very heterogeneous group of applicants. And the challenge is, how do you get some sort of basal and bedrock understanding of what you need to know, what you need to learn with a very diverse group of people who come from very different backgrounds.
Yeah, I can't even imagine the challenges. I mean, when we both trained, the vast majority of programs were, predominantly anesthesia, with you mix in a handful of physiatrists into the realm. And I think generally speaking, at least the sense that I always got going through training, going to interviews, talking to people, was that you knew what each person brought, right? What those skill sets brought. You knew that, anesthesiologists already had some pretty significant procedural skills, and they generally knew their medications and pharmacology extremely well. You knew that the physiatrist generally understood a well-rounded patient-centric focus on function, and usually had a very stalwart physical exam and ability to work a patient up. And so I think knowing how to fill the voids in each of those skill sets, I think, was probably a little bit more straightforward when that was the vast majority of people that were applying to fellowships. You can't even imagine trying to figure out what, an ER or radiologist or a internal medicine physician, what experiences they have, where those knowledge gaps are, and then having to fine tune that education so specifically, for 6 different people.
Yeah, and along with that reality is just, with that changing demographic and waning interest, to restate and I guess update everyone where we're at. I mean, this year, 36 programs did not fill. There were almost
Wow.
70 unfilled slots nationally. So our specialty is going through a little bit of a tough time right now.
Yeah.
And it's really, I think, personally for me and for others who recruit the next generation every year, it happens in this 9 month cycle every year. I think the idea is, what is our messaging? What do we put out as the fundamental values that we have as a specialty? What do we stand for? How do we treat our patients? And how are we going to move forward? And that's where we're at.
So I don't get to spend a lot of time with anesthesia residents. I do have the UC Davis anesthesia interns rotate with me at the VA. And so they spend I think 2 afternoons with me during their intern year, which obviously is not very much, but gives them, a little bit of exposure, or at least a taste of what it is. But from the perspective of somebody who comes from anesthesia and has hopefully, I think, a little bit better pulse on what's going on with the mindset of residents coming out of that residency, do you have a feeling as to kind of why things have been changing so much?
Yeah. I mean, it really boils down to one thing, which is money. It's really hospitals are suffering right now. There are not enough anesthesia providers. And so, whether it's a hospital-based practice or even some of these private groups, these residents are being offered very high salaries, much higher than 4 or 5 years ago, which I say comes at a price, right? It comes at a price with your men, what the expectation of work is and taking call, but it really boils down to a very attractive job market, being able to find a job geographically, basically anywhere, which is historically and even currently a complaint of fellows. And I think pain physicians anywhere really is that it can be hard to find a job or it can be challenging to find the right job, but anesthesia is really wide open. Keeping in mind that the joke I always say is a lot of these large hospital-based practices, I say, do you believe you're actually covering your absorbent salary with the amount that you're billing? And the answer is no, right? The hospital is willing this. They're subsidizing you to do this clinical work. And when you're taking money from someone else, that can ebb and flow, right, with the need and when the demand is met. But the reality is that they're taking these jobs and for the foreseeable future, likely will not change. And as a result, of the 400 plus spots that are available nationally, I fully expect every year that 10 to 15% or more will not be filled, which presents a problem for, the demand that pain physicians we that we're in demand for treating patients, but at the same token, people are following the winds of where the money goes, and I understand that.
Yeah. I mean, I think it's so interesting, right? I mean, having been around medicine for, 20 years now, you've seen the ebbs and flows of how things happen. And, I mean, there was a time, 15 years ago or so where anesthesia reimbursements were extremely low and the job market was very poor. And now, especially, I mean, even just looking in our market here, which you would think a lot of people would want to be in California and, generally a very desirable place. And, we have at our surgery centers that I go to, there's always rationing of available OR space and, when in anesthesia time, because there's just not enough providers. And so it is a
Right.
very, very, very interesting dynamic that we have. But one of the other things that you brought up was this the branding that we have, the story that we tell about what we do. And I think that kind of flows a little bit into a recent editorial that you made, commenting on the way that we're presenting ourselves, to the residents, to the world, in terms of what we actually do for a living as, pain medicine physicians.
I think the hard reality is this: we have become increasingly interventional. That is undeniable. And our spine surgery colleagues, whether it's neuro orthopedic spine, have become increasingly minimally invasive. And I always describe it that we're now stuck in a Hunger Games arena in some respects, and everybody's picking up a sharp object and pointing it at each other. And that's not an affront to surgeons, but the space is tight now. It's ever increasingly this blurred line between practice creep and, in some respects, surgeons feeling that we're doing things that we should not be doing. Um, and there's definitely a political dance and conversation we need to have to prove value of things that we're doing and working collaboratively in that environment. How does that come into our reputation and our messaging? Well, I think the hard reality is we have this now increasingly heterogeneous group of people interested in coming into the field, and it's really understanding and people understanding what that involves, right? We are not a purely procedural field. We are not a purely surgical field. I feel very strongly about the word pain physician, or the group of words pain physician, that we should call ourselves pain physicians, because it's not just about procedures. It's not about spinal cord stimulation, although I do spinal cord stimulation and dorsal ganglion stimulation, peripheral nerve stimulation, minimally invasive spine. I do all of that, but I feel very strongly that we need to message and position ourselves that we are taking care of not only the procedural aspects, but also taking care of patients who may not need procedural intervention at all or are not good candidates for procedural intervention. I tell the fellows all the time, the best thing you can learn in fellowship is not who to do procedures on. That is the best lesson, not who is appropriate for what procedure per se, but who is not. I know that's controversial, and I know, in that editorial, that is not an affront to any one person group, but there has been this narrative that has really been a drumbeat, particularly with candidates, really focused on this idea of just the advanced things. And we talked about that. And people calling themselves, they'll go as far as even say this idea of quote pain surgery, which I think is not a good idea for messaging. And the reality is when we say stuff like that, the surgeons laugh at us.
Yeah.
They do. I mean, it's not what we are. We,
Yeah.
and I think in this lull, we are at this low right now in recruitment. It's really important that we reflect and think about what we stand for. I joke with my fellows all the time. There is a dirty word. It's a 5-letter word, and it's called clinic. Is that 5 letters? That's 5 letters. Five or
5 letters.
six? Five
Yeah.
letters, yeah. Clinic's 5 letters. But there's a dirty 5-letter word called clinic, which is that being good in clinic and seeing patients in clinic is just as important as being good in the procedure suite. But I think that is I bring up that analogy because there's sometimes, and even my program, we've been guilty of this, meaning you have really emphasize this whole idea of procedures, and then fellows show up and they arrive and you're teaching, and you realize, you say, hey, look, clinic is just as important. They're like, oh my gosh, wait. And oh, if and Brian, you could speak to this. In private practice, you want me to see how many patients in a day? I try to say, hey, look, the most amount of patients, our fellows in a lot of programs to teach, to learn, to write your note, they may see 10, 12 patients, but that's not going to keep the lights on
Yeah.
in the private practice realm. You're talking, 30, 40 patients in a day. And so it's those skills, or this idea that, hey, you want to do basivertebral ablation. That's great. Or you want to do some sort of intraspinous spacer. How do you read an MRI? What are modic changes? How do I measure a ligamentum flavum? Frankly, are not even sometimes mentioned in an MRI report. That's a whole
Right.
other nuance onto itself, is imaging. And so there's all these things now that I think we really need to emphasize. We really need to take a step back and really look at what we are.
Yeah, no, I mean, I think, as I've had the pleasure of interviewing and meeting, docs that have trained across the country, I think one of the things that has always stood out to me over, particularly over probably the last 4 or 5 years, is that as you're talking to the people about their experiences, and I'm trying to help them to understand, what's necessary in a private practice role, right? Whether that's just the volume of patients that you need to be able to see, the way that we need to be able to communicate with patients to educate them the right way, so that the way they understand what we're doing and why we're doing it. Because I think that, our patients understanding what and why we're doing is so important for us to actually achieve a desired outcome for the patients, or even just like a simple fact of, medication management. I think, you brought up earlier, like with a lot of the things that, we learned in our times of fellowship, there are multiple clinics with our educational programs with very large names, very well respected, that I've talked to the fellows when they're finishing, and they're like, yeah, I never prescribed an opiate. Like, we never really talked about, multimodal medication management for these patients. it's not really something that we did, which to me kind of blows my mind because, it's one of the steps on the ladder that we have, right? I mean, we have tools and some of them are fantastic interventional options. And like you said, it's not that I'm trying to speak bad about it. I do them. I love them. I think they're phenomenal ways that we can help our patients. But there's this whole, moat of patients that they're not appropriate for, or that can do well with a, simpler, potentially less invasive option that more suits the patient's desires. And so I think that's, it is kind of interesting to see how that's evolved when it did used to be such a large part of the educational process.
Another thing to bring up, and once again, not without controversy. By the way, clinic is 6 letters.
I realized that after I
Yeah,
spelled it
I
while you were
know. I
talking. I
know.
was
I
like,
know. People are going to watch this and be like, "Oh my God, these guys, these yo-yos," right? Um, but the other thing that came out, we had published this in January, February last year, um, which really came out of this idea of, I called it the nuts and bolts of pain medicine. I actually broke down what a year was on paper, because when you're training, it's not a year, it's 45 weeks. Once you take away vacation and meeting time and all the holidays we have. And we had around 90 folks, we call them luminaries from around the world, sign on to this document that pain medicine should be extended, that the fellowship training experience should be extended in some way, shape, or form. We didn't agree upon a time per se, but it really, and people have had numerous thoughts on this. Some people say, for that first year, it should be very much focused on this idea of basic intervention, imaging interpretation, all the kind of multidisciplinary care. And then if you were going to move on to a second year, that's when you would start really honing in on some of these advanced procedures. Other people have said this idea of a residency. Other people have said, a whole host of things. But the reality is that this included program directors. They included some of the what I consider to be OG founding members of the field, 30 plus years. And everyone pretty much agreed that how we're doing things now is probably going to be unsustainable. It will probably be unsustainable in the near future. And where do we move on from here? But it brought up this idea. I was just happy that people were passionate and arguing about it, whether whatever option that ended up being. But that was something else that had come out this year that I think was transformative for pain education.
Yeah, I mean, I think one of the things that I've always kind of compared where we are in pain and spine to was like the cardiology, cardiothoracic kind of development, 20 years before us, right? Where as interventional cardiologists developed more skills and more ways of being able to help patients, it started to kind of impede a little bit on cardiothoracic surgery. And I think there was at some point they went through a turf war. But if you think about cardiology and interventional cardiology and cardiothoracic surgery, right, there's a different level of education for each of those, right? And so,
Yeah.
cardiology is
Three,
its own
three,
fellowship.
3 years to become an interventional
Then exactly, and
cardiologist.
then you
Three
have
years.
you have an entire, equally length training program to become an interventional cardiologist, right?
Yeah.
And thinking of just the evolution of our field. I mean, it even makes me think like, even in our community, and I'm sure this is just about in every community everywhere, there are people that do a lot of the things that we've been talking about that haven't even been through a fellowship, right? I mean, they either learned way back in the day, or there's a handful that are still relatively in the same age demographic that we are in terms of years of practice, but didn't go through pain training or any type of NAS accredited spine fellowship or something like that to be able to learn these things and are performing these procedures, right? And so I think that as you start thinking about the layers of this onion of education and training, I mean, obviously, like there are these people that don't have any of the training that we've been through or that we would consider to be necessary to get people there that are performing them and seeing these patients and trying, doing their version of trying to help, which, as a person who generally tries to believe in the best in people, I hope and believe that they're trying to do their best, but, probably not necessarily something that many of us would consider to be the standard of care, or up to what we would hope for our communities.
No, agreed. Yeah, totally agree.
It's funny. Here locally, we both have the pleasure of being friends with Dr. Sheth, and Dr. Sheth's a phenomenal guy. And I know for probably 5 or 6 years, we've chatted about trying to create a community standard of what we expect out of people who do the things that we do, right? And whether that's in terms of education or training, or even just I'm personally not a fan of the some people that will do one procedure one time in 5 years, and some of these procedures I don't know that you can be very competent at if you do them one time in 5 years, right? And I mean, I think that there are times where we have to figure out what's going to be the best for our communities, because these are where we live. These are the patients that we treat, and and obviously these are the primary care doctors and overall that we're trying to fill those voids for.
Yeah, not everyone's going to be good at everything. And that's another narrative that's out there is regional centers or groups of excellence. I believe in that very strongly. But how we message ourselves, how we comport ourselves, how we're packaging up what we do, it also matters. It matters very much. And I'm pretty passionate about it just because I want one of my you know collaborators and colleagues at Montefiore, Syed Wahazy, he is always he's pretty vocal too, and he has made this comment that I'm worried what's going to be left. Is there anything going to be left for us? And I think there's some truth to that. Meaning, if we don't do a good job with data, we don't do a good job with training, some of these therapies will just go away. They'll go away, or someone else will take them from us. And I think it's really important we pay attention to that. And the training piece, like I talked about, is essential to that equation for the survival of pain medicine.
Be theoretical and say that we just kind of scrapped the current system, and
Sure.
we're thinking of the best way to be able to train a pain medicine physician of 2030. We'll just say we're looking at somebody who's coming out of medical school this year. They'll be graduating, and we're looking 5 years down the road. What is the best path to make sure that they are able to develop the skill set of patient evaluation, understanding their resources in their community, being able to communicate well with the patients and educate them in the right way, learning all of the different tools that they have available to them, and also being able to provide the services in a way that meets or exceeds the standard of care for those procedures. What do you think would be the best way of training that future physician?
The utopian vision would be a residency, right? Which is such a it's a challenging idea, but it would be a multi-year, 4-year residency training program. This whole idea of PM&R, anesthesia, it's kind of in some ways silly to me in the sense like even as a program director now, we have 5 physiatrists coming in next year, by the way. We've matched 5 physiatrists. Primary specialty, I think we're in such a radically different territory compared to 10 or 15 years ago, because some of the old salts will say, we tried this, we tried to have this argument, right? And it failed. It's like, but it's so different now. I mean, we're
Yeah.
talking about really just a budding now with kind of the tip of the spear when it comes to some of the technological things that are out there. So a residency would be the best scenario. Now, a caveat to that is what is more practical? A more practical scenario is a 2-year fellowship. And once again, I've caught the hate, I've caught the vitriol, I've gotten the DMs and whatever, the emails saying you're crazy, no one's going to pay for it. But no one ever wants to hear the argument, which is the argument is I'm not saying double the amount of complement of pain physician training spots in the country. I'm not saying that at all. All I'm saying is split your complement in half. So I would have 3 fellows 1 year, 3 fellows the next year, not 6 fellows per year.
Yeah.
And now I have solved both the training issue of getting enough reps and experience, both clinically, you know, with electives, with OR experience, with working with our surgery colleagues. I've solved that problem, but I've also solved the problem that our recruitment right now is totally in the toilet. The
Mhm.
fact that we have literally 40% applicants who are applying, we have solved two problems, and it costs no more money in the sense of salaries, and you're just splitting your complement, you're splitting the amount of fellows you have. So there is the utopian view of what I would really love, but there's also the more realistic view of that it's 2 years. And, if you're particularly, this would be a fight in the beginning that not everyone may be an adopter, but a group of us believe fundamentally, including many program directors, that 2 years would be a much better option for, putting out a better product.
Yeah. No, I think that's an extremely practical approach, right? I mean, I think that, I would agree. I think at this point, the world of pain medicine is drastically different than it was a decade ago. So, the thought of people applying now just the same way that you or I did is, it's so different. The world is massively changed in the scope of the practices. But yeah, I mean, the practicality of being able to separate that. I mean, I would almost argue that looking at this from like the private practice outside perspective, I mean, the overall cost to the system by having people that aren't ready to do these things and to actually care for these patients is already there, right? We're just kind of shifting it where we're paying those costs, whether that's mistreatment of patients or adverse events or things along those lines, or even just not people not actually being ready to see the patients in the right way. Right? That cost is already there somewhere by the trainees not being quite ready to fully embrace the breadth of what we have in pain medicine.
No, agree. Totally agree.
I mean, it's interesting as you're saying that I'm like now my mind starts spinning around in circles just because it is such I think an interesting idea. But I mean, I guess the other side would then be we already talked a little bit about the monetary constraints and why and how anesthesia has been decreasing as they've had a lot of opportunities. 2 years does change that perspective also, right? I mean, I think even you know anesthesia and PMR are the primary specialties historically going into pain medicine. Even as PMR salaries have risen, the extra year I think people can justify. 2 years does start to bring that part in too, where the the monetary decision becomes a little bit more challenging, which may
No,
actually be a good thing, right? Where it's really drawing people that truly care about this field and truly want to be able to serve this population in the right way.
yeah, I mean, I totally agree. And like I said, the ultimately down the road, it would be incredible to have its own residency, 4 or 5 year residency, and then you just leave, and when you're done with residency, you're a pain physician, or whatever you want to call it. But the short term, there's been a lot of creative people who have brought up a lot of interesting ideas. Some people have argued that not every center is positioned to offer advanced training. And I'm not even talking about advanced procedures. I'm just talking about advanced training, meaning I brought up buprenorphine earlier, but for example, our fellows rotate every week with a pain pharmacist. We have a pharmacist in our group, and she is just phenomenal at initiating buprenorphine with patients who are on intermediate to high dose opiates and transitioning them from, say, something like oxycodone to buprenorphine. That is an art form in all itself, right? And that has nothing to do with intervention, but that is a very nuanced, very complicated sort of intervention,
But very relevant, right? I mean, I
but
think
very
that
relevant, very
you
relevant.
think
I
of
mean,
something that serves a community really well, us
yeah,
being able to help
yeah,
patients get onto what is at this point
yeah,
presumed to be a better and safer alternative for
yeah.
them is a big deal.
Yeah, when you have 100,000 people in the United States, around 100,000 people dying every year from opioid overdoses, much of which is a lot of it is related to illicit use, but it's this whole intersection of substance use disorder, chronic pain, mood disorder, aberrant use of opioids, and so it's just another thing, right? People argue and say, well, that's not available at our program, so why does it need to be 2 years? Or other things that come up. I mean, for example, our trainees rotate with our neuroradiology group and really take a deep dive into reading advanced imaging like MRI. That's something I never did. I never did that as a fellow. I read reports. I'm embarrassed to say it, for the probably first 3 to 4 years of my career, I was just reading MRI reports. I would kind of sometimes glance at the MRI, and now I am obsessive compulsive about looking at MRIs, looking at foraminal stenosis, looking at central canal, all these things. And that takes time. And so some will say, oh, well, we don't have that experience, or it's a small group. So it's a challenge. The reality is this. I mean, it is a challenging discussion. It's uncomfortable when you ask trainees about it. There's a recent survey that we looked at and some of my collaborators sent out, and trainees were like, absolutely not. If this were 2 years, I absolutely would not do it. They say that, but it's one of those things that's like, you don't know what you don't know.
Yeah.
And when the bar changes, it's a whole new generation. They say, well, this is what it is. If I want to be a pain physician, I got to do it. But I'm just happy that we're having the conversation, that people are debating, people are getting upset, are doing this, because I think it shows that it's really building steam and it has credibility for sure.
Yeah, no, I think it's a phenomenal discussion. Like I said, I think, just, you know, understanding that, what we do is, I think thankfully both of us agree is so important, so necessary. And it's so nuanced, right? There, so much of what I teach now within my practice when I'm talking to the younger docs that are working with us, or the APPs, is about, the education and the communication. Like,
Yeah,
it's that's I spend so much time on that, much more than, 5, 6 years ago. I think I spent so much time trying to educate them about the procedures, about the medications, about, the actual facts of what we do. And now, being what I like to believe is the more mature version of myself. It's so much more about like the softer skills of how we actually can do this, right? We have these tools. How do we actually turn this in? And I think that's so much of the training is, we have to learn it, and then you have to learn how to implement it, right? And being able to create, good physicians takes time.
it does. And for a private practice such as yours, it when you have a new grad, when you have someone who's brand new, we spoke about this. It's a huge mentoring decision to bring in a new grad to your practice, which is fast paced. It's a huge deal. It takes a lot of time, effort, and dollars on your part to train someone to that level or standard of seeing 40 patients in clinic and doing 20 or 30 procedures in a half day. I mean, it's a lot. It's a lot. And then having all of that post-visit communication and follow-up and communicating with other consultants. It takes a lot of time, effort, and energy to do that with what we generate as a current grad and product of fellowship.
It is a ongoing work for both of us there. Ongoing work.
Sure. Yeah.
Well, I appreciate you so immensely for taking some time. Final thoughts that you have for our audience, as they're, generally, med students, residents, earlier career folks, as we're kind of wrapping things up here.
I think despite some of the challenges that we spoke about in the field of pain medicine, it's an incredible field. And I think more than ever, we have enormous power to impact people's lives in ways that we never could do before. And I say this to folks that are in medicine, even my own family members that say, are you glad you did it? And are you happy? And the answer is absolutely. I mean,
Yeah.
we are enormously fortunate to be part of this field, to lead the field. I tell everyone it's a small community. It really is. And I think we have really good leadership nationally and internationally in pain medicine, folks like yourself. So I say onward, I say forward. Let's do it, and let's continue to innovate.
Awesome. Dr. Pritzlaff, I appreciate you so much. Everybody, please, if you're listening, send a message to Dr. Pritzlaff. Tell him how much value he brought to you today, and tell him that he should come back so we can talk about something maybe a little bit more specific in regards to actual treatments for patients in the future.
Awesome. Thanks, Brian.
All right, Scott, thanks so much, and we will talk to you guys next time.